Have you ever wondered what it's like to be in the hot seat for one of those high-stakes surgical exams? Well, today, we are going right inside the Viva. We're going to walk through two classic endocrine surgery cases, and I'll break down exactly how to think, how to act, and how to respond like a top-tier surgical candidate.
So just take a deep breath. Imagine you're in the exam room. You're sitting face-to-face with the examiners. The pressure is on. And listen, this isn't just a test of what you know. It's a test of your structure, your safety, and your surgical judgment.
So here's the deal. For this explainer, you are the candidate. I'm going to be your examiner, and I'll be throwing the tough questions your way. But I'll also be your guide, showing you how to knock those answers out of the park with clarity and confidence. You ready to dive in?
Okay, here's our game plan. We're going to tackle a tricky parathyroid case first, then an adrenal incidentoma. After that, we'll shift gears into a rapid-fire surgical masterclass, and we'll wrap it all up with the examiner's final debrief.
All right, let's begin. I'm your examiner now. So, your first case. You have a 43-year-old woman. She's perfectly healthy, no complaints at all, but her routine checkup flags some high calcium levels.
So, candidate, how are you going to approach this patient?
Thank you, examiner. My approach is going to be systematic. I'd start with a really detailed history, looking for any of those classic symptoms of high calcium, things like bones, stones, moans, and groans, and of course, any family history of endocrine problems. Then I'll do a focused physical exam, paying close attention to the neck, even though it's often totally normal. From there, I'll build out my differential diagnosis, line up my investigations, and then come up with a solid management plan.
My differential diagnosis here has to be broad. Right at the top of my list is primary hyperparathyroidism. It's just the most common cause for an asymptomatic outpatient like this. But I absolutely have to rule out malignancy, which is actually the most common cause in patients who are already in the hospital. I'd also be thinking about less common things like FHH, which can really mimic hyperparathyroidism, and then, of course, drug-induced causes or things like sarcoidosis.
Very good. Okay, let me give you the results. Her blood work shows high serum calcium and a high parathyroid hormone level, or PTH. Her 24-hour urine calcium is normal, which pretty much helps us rule out FHH. A neck ultrasound suggests there might be a left inferior parathyroid adenoma. And then a systemicity scan, that's the one with the radioactive tracer, it confirms the finding. Thank you. Well, with high calcium, high PTH, and that normal urine calcium, this is a clear-cut case of primary hyperparathyroidism. And the scans are pointing directly to a single adenoma, which, is the cause in over 85% of these cases.
So my management is going to be surgical. First things first, I'd sit down with the patient, explain the diagnosis and why surgery is the best option. I would get a baseline vocal cord check because that recurrent laryngeal nerve is at risk during the operation. Then I'd consent her for a focused left parathyroidectomy, making sure to talk through all the key risks: bleeding, nerve injury causing a hoarse voice, and post-op low calcium. In the operating room, I'd plan to use intraoperative PTH monitoring. A drop of more than 50% after we take the gland out tells us we're done. And of course, all the standard pre-out prep would be arranged.
Excellent. Let's move to the next case. You've got a 55-year-old man who had an abdominal ultrasound for something totally unrelated, and they found a 3-centimeter mass on his left adrenal gland. How do you approach this?
For any adrenal incidentoloma, I always use a 3-question framework. First, I need to confirm it's actually an adrenal lesion, usually with a good CT scan. Second, and this is the big one from a safety perspective, I have to find out if it's functional. Is it pumping out excess hormones? And third, I need to assess its malignant potential, looking at things like size and how it looks on imaging.
Now, this slide really highlights the complex anatomy of the adrenals. They have this incredibly rich blood supply from 3 different arteries, but usually just one main vein draining everything. Surgically, the right adrenal vein is a huge deal. It's notoriously short, it drains right into the vena cava, and it's incredibly easy to injure if you're not extremely careful.
The list of what this mass could be is pretty broad. Answering those questions about functional and malignant means we have to work through all these possibilities. You've got functioning tumors like pheochromocytomas or those causing Cushing's or Conn's. Then you've got benign non-functional things which are really common. And you always have to consider malignancy, either a primary adrenal cancer or a metastasis from somewhere else.
Okay, but first and foremost, we have to rule out a pheochromocytoma. This is an absolute, non-negotiable safety step, even if the patient has 0 symptoms. So I'd ask about that classic triad: headaches, palpitations, and sweating. And I'd order a 24-hour urinary metanephrine screen. Missing this diagnosis and going to biopsy or surgery unprepared can be catastrophic.
And if it is a pheochromocytoma, the pre-op preparation is everything. You have to start with an alpha blocker, something like phenoxybenzamine, for at least 10 to 14 days. This controls the blood pressure and lets the patient's whole circulatory system re-expand. Only after that's done can you add a beta blocker to control the heart rate. If you get that order wrong, you risk what's called unopposed alpha stimulation, and that can trigger a life-threatening hypertensive crisis.
All right, candidate, let's step into the operating room. I'm going to hit you with some rapid-fire questions now. I need precise, confident answers.
You're doing the neck exploration. How do you tell the difference between a parathyroid gland and a lymph node? Well, a parathyroid gland has a really characteristic golden brown, kind of caramel color. It's often tucked away in fat, and when you cut that fat, it just tends to pop right out. A lymph node, on the other hand, is usually whiter or beige, it can have a glassy surface, and it feels a lot firmer. If there's any doubt at all, you send a frozen section biopsy to confirm.
Okay, you can't find that left inferior parathyroid adenoma where it's supposed to be. What is your systematic search pattern? My search has to follow a defined anatomical plan. First, I'd explore the thyrothymic ligament and the thymus itself because those inferior glands can actually descend with it right into the chest. If it's not there, I'd open the carotid sheath. Next up, I'd check for a rare intrathyroidal gland, maybe even use an intra-op ultrasound. If all of that fails and my pre-op scans were really convincing, I'd have to consider a thyroid lobectomy on that side as a final step.
Now you're removing that pheochromocytoma. What is the single most important technical step of this entire operation? The crucial point, without a doubt, is early ligation of the adrenal vein. This has to be the first major step, and you have to do it with minimal handling of the tumor itself. Why? Because you've got to prevent a massive, potentially fatal surge of catecholamines, adrenaline and noradrenaline, from being squeezed into the bloodstream as you move the gland around.
And this slide here shows you the modern way to do this, a laparoscopic left adrenalectomy. You can see the typical port placement just below the rib cage, with the patient lying on their side. This minimally invasive approach gives you fantastic visualization and a much faster recovery, as long as you stick to those principles of safe dissection.
Very well. That concludes the case discussions. So let's debrief. You see, passing the viva is about so much more than just knowing facts. It's about proving that you are a safe, thoughtful, and systematic surgeon.
So what are the big takeaways from all this? First, always have a structured, systematic approach. Second, you have to know your differential diagnosis cold. Third, remember the critical safety rules. You never biopsy a suspected pheochromocytoma, and you always ligate the adrenal vein first. And finally, you have to be ready to manage the key post-op complications like low calcium after parathyroid surgery or an adrenal crisis.
We've covered a ton of technical details today, but I'm going to leave you with this final question to think about. What is the most critical, non-technical skill for a surgeon? Is it communication? Is it judgment? Teamwork? Because that's what really elevates a good technician into a great consultant.